Hello friends, now we are starting a new series following the footsteps of Oxford Handbook of Infectious Disease and Microbiology. This is exclusively for ID preparation, and if you want you can refer these lectures to have a better understanding of some important antivirals. We are starting with Herpesviridae family. So Herpesviridae family have something very much common in them. All the family members having some sort of latent infections in them. That means they might be hiding in certain places in the body, like trigeminal ganglion in case of HSV1, sacral ganglion in case of HSV2, and in case of EBV there is memory B cells, so they might get reactivated future in the life. So that is something which we will reserve for some other lecture some other day. Today we are learning the antivirals. So before going to the antivirals, we should know that which class belongs to which subset. In case of 4 and 8, they belong to gamma subset of the Herpesviridae family. Why they have been placed in the gamma subset? Because they both have oncogenic potential. They can be cancerous. Like the fourth is EBV. EBV is Epstein-Barr virus, which causes nasopharyngeal cancer, Burkitt's lymphoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma. In case of 8, it causes Kaposi sarcoma. Apart from that, the first three, that is HSV1, HSV2, and third, that is varicella zoster virus, they belong to alpha family. And 5, 6, 7, they belong to beta family, in which 5 is CMV, 6 and 7 are roseola. So what is the basic mechanism of these antivirals? In case of herpes simplex and varicella zoster. So viruses are having some sort of enzymes in them which are called protein kinases, like thymidine kinases. What these viral specific protein kinases will do, whenever you are giving a drug from outside, some sort of active form has to be formed for that drug, and these enzymes will act on this drug and form this active form. So basically what they are doing, they will be phosphorylating the active form, and then the phosphorylated form will act on the DNA polymerase. It might act by terminating the chain or terminating the elongation. So first come first is acyclovir. Acyclovir is a nucleoside analog which resembles guanosine. So basically it requires the thymidine kinase to act. Thymidine kinase will convert it into the active form by phosphorylation, and so it can go and inhibit the DNA polymerase. Basically 3 phosphorylation are required in case of acyclovir. The first is due to virus specific protein kinase, and the second 2 enzymes are due to the host specific cellular kinases. So how they act? In the mechanism of action, if we see carefully, acyclovir will go and competitively inhibit the DNA polymerase. How? By binding to the DNA, and once it binds to the DNA, further nucleosides cannot be bound with the DNA chain. How come resistance will come in acyclovir? As thymidine kinase is the specific enzyme which is required for the activation. If in any case it is absent or altered, there will be resistance of acyclovir. And second will be the decrease in affinity to DNA polymerase. So what is the route? The route is IV, peroral or topical. We can't use this drug in pregnancy, neither in breastfeeding, neither in CMV cases. Why? Because the CMV lack the thymidine kinase. That's why acyclovir won't work on the patients having CMV infections, even though if it might show in vitro sensitivity, but still it won't work. The side effects are, in absence of proper hydration, this acyclovir can go and crystallize in the kidney. Plus there can be neurotoxicity also. There is another form of acyclovir where a valine ester is inserted in the drug. It is called valacyclovir. What this valine will do, it will increase the bioavailability of the drug. But the side effects are thrombocytopenic purpura and HUS. Thrombocytopenic purpura and HUS. Antivirals for CMV. Now we come to second category, that is the antivirals for the CMV. We should start before starting this category. We should know that CMV in itself can suppress the bone marrow, and so the drugs which we give from outside, they might also contribute in the same. So it becomes really difficult to know that whether the drug is causing the suppression or the virus itself is causing the suppression. Here, as we know, thymidine kinase is lacking, so acyclovir won't work. The main mechanism is inhibition of DNA polymerase. So how this inhibition occurs? They can occur by inhibiting the protein kinases. In case of there are two main drugs, which is ganciclovir and foscarnet. Ganciclovir is given IV only, whereas ganciclovir have this valine ester which increases the bioavailability. So how this DNA polymerase is inhibiting? In case of acyclovir, we saw thymidine kinase was something which was inhibited, but here there are different sort of viral kinase, that is UL97 kinase. In case of foscarnet, it is UL54. So what are the side effects which are seen in ganciclovir? Main is bone marrow suppression and kidney dysfunction. In case of foscarnet, which is used as second line drug for the CMV if they are resistant to ganciclovir, here what happens? Enzyme inactivation takes place. Direct enzyme inactivation will take place, and so DNA polymerase won't work. The side effects are, it is nephrotoxic. Now we come to cidofovir. Cidofovir is another class of drug which is a broad spectrum drug for DNA viruses. And how we remember DNA viruses? By a mnemonic called HAPPY, where H belongs to herpes, A adenovirus, P papillomavirus, P polyomavirus, polyoma example PK virus. How does it work? It disrupts the nucleic acid synthesis, which inhibits the DNA polymerase. So one thing common we are seeing here is all of these drug classes will be inhibiting DNA polymerase in one or another way. The route here is IV. Activation not required in case of cidofovir. Why this activation is not required? Because virus specific kinases are not particularly required for the activation of cidofovir drug, unlike other drugs which we have seen. So it will work nicely for all the resistant strains of HSV and CMV. The side effects are renal impairment. We can't give this in pregnancy, breastfeeding. It causes neutropenia and Fanconi-like syndrome. There's one new drug which is called letermovir. It targets the late CMV replication cycle, inhibiting the packaging of the viral DNA to form mature progeny. So in case of the hematopoietic stem cell transplant patient where the donor is positive and the recipient is negative, this drug is very helpful. And an extra edge is, there is a higher risk of acquiring CMV infection if the donor is negative and recipient is positive in case of hematopoietic stem cell transplant patients, because there won't be any memory T cells in the donor. Eventually all the cells of the recipient will be replaced by the donor cells, and if the CMV gets reactivated, there will be no protection which can be given against this reactivated virus. Thank you, and hope to see you again in the next lecture.